question mark on it, and if you will put any questions that you have for our speaker in that section, it will go directly to the speaker, and it will not get mixed in with all of the chat that there may be. So if you would do that, that would be great. Don't forget also that in the end of this presentation, there will be a virtual happy hour that will be going on, and there are 2 sessions of that happy hour that we invite you to participate in. If you haven't heard, there are some prizes that are going to be given away in different sessions, not necessarily announced ahead of time, but for this session, I will announce to you that this session does have a gift card that will be given at the end of the session, so please hang in there, and we will give that to one of the folks here in our presentation at the end. We do have a sponsor for this session, and that sponsor is Cipher Health. So I'm going to introduce David now and give him some time to speak with you about Cipher Health.
Thank you, Connie, and good afternoon, everyone. As Connie mentioned, my name is David Cox, and I'm joined today by my colleague Kyle Herndon as well. Both Kyle and I serve as customer relationship executives, and we're delighted to be here with you today. For those of you that are unfamiliar with Cipher, we're a patient engagement company. We're headquartered in New York City with additional offices in Nashville and San Francisco. We're an established technology company solely focused on enabling purposeful conversations throughout the care continuum, from pre-care, care activation, point of care, through post-care. And over the last 10 years, we've partnered with many provider organizations to enable quantifiable outcomes, including clinical, operational, and financial. And we're proud to claim many luminary organizations as customers, including several provider organizations represented here today and tomorrow. So thank you. With a heightened focus on consumerism in healthcare, we're growing rapidly due to our performance and ability to scale our unified digital platform. You may recognize our solutions from appointment reminders, digital rounding tools for patients, staff, and locations, and our customizable episodic outreach. In short, we're proven, we're growing, and we're capable of delivering an enterprise experience across the care continuum. So again, thanks for having me in Cipher Health. We're proud to support both Kentucky and Indiana HIMSS chapters, and we hope you find the spring conference valuable. If you'd like to learn more about Cipher and explore how we may be able to support your organizational patient engagement objectives, you can reach out to me directly at my contact information in the community. Or, as an alternative, Kyle will be hosting the coffee break tomorrow afternoon at 3:15. So thanks again. Connie, I'll turn it back to you.
Thank you. Well, so I want to go ahead and introduce to you your speaker. We have Dr. Victor Lee, who will be speaking to us on the topic of COVID-19 Interoperability Alliance value sets. So we appreciate that you are here with us today and are going to be providing us with all this great information. So without any further ado, I will let Dr. Lee take over.
Great. Thank you, Connie. And welcome, everyone. Good afternoon. I'm pleased to be here this afternoon to spend a little bit of time talking with you all about the value sets that we've created under the COVID-19 Interoperability Alliance. First, a little bit about myself. I am Victor Lee. I'm VP of Clinical Informatics at Clinical Architecture. Clinical Architecture is a company whose mission is to deliver innovative solutions that maximize the effectiveness of healthcare. And the way we do that is through terminology management solutions focused on interoperability and data quality. And so it's with that context that I'm here talking to you today about what we've done with the COVID-19 Interoperability Alliance and the value sets that we've created I've listed the session objectives here. You probably have already seen them, so I'm not going to go through them in detail, but I will say that in addition to the first two objectives, which are kind of going to be addressed in some of the background information, I'm really going to spend most of the time here on the third objective, sharing some best practices for value set authoring and maintenance. So with that, I wanted to talk a little bit about the role of semantics in health information technology. And I'm not going to go through this in detail, don't worry. I know there's a lot of words on this slide, but this is the HIMSS definition of interoperability. And the main point here is to set a kind of a foundation where there are multiple aspects that feed into interoperability. And while we're often talking about structural interoperability when we have conversations about things like FHIR and continuity of care documents and HL7 messages, those are all structural aspects of interoperability. But sometimes what gets swept under the carpet are conversations about semantic interoperability. And that's where we have terminologies where meaning is ascribed to certain structured terms. And so it's that payload of semantics that fall within things like FHIR messages and HL7 messages and CCDs that actually give meaning to what's going on with a patient. And so it's that kind of interoperability that we're referring to when we talk about value sets. So if you want to learn more about this definition of interoperability, there's a link at the bottom. But that's the key message: is the focus on semantics is what this presentation is about. So when the pandemic struck, what we found at Clinical Architecture, and really this is the brainchild of our fearless leader, Charlie Harp, is that we noticed a lot of organizations were sort of reinventing the wheel when it came to semantics, and namely around terminology and value sets. That if you wanted to do clinical research or analytics or decision support, or if we were trying to figure out what terms would roll up to different fields in a case report form, people were kind of reinventing the wheel. And because we're terminology experts, we decided that one way that we could give back to the world and contribute to the world's knowledge about COVID-19 was to stand up the COVID-19 Interoperability Alliance and help people meet some of their terminology challenges. And so these are some of the use cases where value sets might come into play, or even just providing guidance around what should go, what kinds of terms should be referred to in an implementation guide. And so the COVID-19 Interoperability Alliance is a collaborative effort between multiple organizations banding together, trying to solve some of these semantic terminology issues related to COVID-19. So we can understand the information patterns and help make better decisions and inform research around COVID-19. This is a look at the COVID-19 Interoperability Alliance website. This is the main page, and you can go there by going to covid19ia.org. And from there are different sections of the website that I wanted to talk about. But first, this is a listing of some of our founding members. So Clinical Architecture got together with a variety of these organizations where you see the logos on the screen. And we've gotten together and had periodic meetings as well as ad hoc meetings to solve some of the problems that I mentioned just a minute ago. On the website, actually a note before going back to the website. So in addition to all the founding members and all the participants of the Alliance, Clinical Architecture serves as the steward of a variety of value sets. And just earlier this week, we crossed the 700 mark in terms of value sets. So these are things like COVID-19 comorbidities like COPD and diabetes, as well as medications, remdesivir, laboratory testing, for things like SARS-CoV-2 PCR tests, and a bunch of other, conditions, procedures, and other things related to COVID-19. So we have more than 700 of these value sets, and we've provided them to the world for free. They have terminology bindings to code systems like ICD-10, RxNorm, LOINC, SNOMED-CT, and other code systems that are conformant with recommendations in the United States Core Data for Interoperability, which is a subset of the terms that are referred to in the Office of the National Coordinator for Health Information Technology and their Interoperability Standards Advisory Guide. So these basically are subsets of information that are expected to be shared across providers, across health systems for interoperability and other purposes. And the Alliance has welcomed feedback from the community in terms of what kinds of value sets across medications, labs, conditions, procedures, et cetera, are desirable for people to understand and to research and to provide clinical decision support around COVID-19. So there's a prioritization process, and I'll talk a little bit more about that. But we've taken input, we've authored value sets, and we've put them out there for the world to consume, to react to, and to continuously improve. So if we take a closer look at the website, there are a few different ways that the value sets can be accessed with varying degrees of latency. The most up to the minute or up to the second access of the value sets is through the workshop. This is a part of the website that does require a log on. It's free, as is all of the content that we've made available through the Alliance. Just contact us and we can get you a login to the workshop. But it allows you to see the latest and greatest version of the value set content. So for any given value set, there are members of a value set. For example, diabetes mellitus could have 100 different SNOMED terms that roll up to the concept of diabetes mellitus. And so you can browse and see those value sets and their members in real time through the workshop. We also have a downloads page where we've taken periodic snapshots of the value set content and we've put them in Excel files for you to download. This does not require a login. We don't need to know who you are. We won't ask. This is just part of the Alliance website, and it's under the downloads page. So you can download individual value sets across individual code systems like SNOMED, RxNorm, LOINC, ICD-10, and there's also a combined file. This was just updated last week, and so there's a little bit of latency there, but it's kind of a one-stop shop area for you to get value sets related to COVID-19. And then a third area where the value sets can be accessed is through the Value Set Authority Center. And the Value Set Authority Center, or VSAC, is hosted by the National Library of Medicine, which falls under the NIH. And as you can see here, you can browse the VSAC value set offering. One easy way to find the COVID-19 Interoperability Alliance value sets in VSAC is to filter by clinical architecture as the steward, and that should take you to the value sets that we have synchronized to VSAC. It's the same content for the most part. There are some challenges we've had with getting every single term in every single value set into VSAC. Namely, it's a little bit of an extra burden for us to take retired terms and put them into VSAC. So some of those might be missing, but for the most part, they should be representative of the value sets. And I'll talk a little bit more about retired or inactive terms when I get to the best practices section. But in summary, the COVID-19 Interoperability Alliance has been stood up to basically be of service to those who need value sets for any number of use cases. They're free to use. We welcome people to join the Alliance and to contribute, or simply to anonymously use the content for your own benefit. And there are many different ways to access the content with varying degrees of latency. I have one slide to give some examples of how different organizations and alliances have used the COVID-19 Interoperability Alliance value sets. One is the COVID-19 Healthcare Coalition, and you can see the link up at the top. And they've actually done a variety of very interesting research studies related to famotidine, convalescent plasma, and now there is a digital guidelines working group under the COVID-19 Healthcare Coalition that is planning to also study long COVID or post-acute sequela of COVID-19. So those studies have either been done or are planned or possibly in progress. MITRE is an organization that is partnering with someone to also study long COVID, post-acute sequela of COVID-19. The AHRQ has a COVID collaborative, and they are also planning to use the COVID-19 Interoperability Alliance website and value sets for COVID-19 related activities. They're defining kind of foundational elements of a learning health system, plan to do clinical decision support, and value sets play a part in all those activities as well. And then finally, Clinical Architecture has partnered with the Indiana Health Information Exchange and the Regenstrief Institute to do a pilot around electronic lab reporting for COVID-19, as well as some other notifiable conditions. So these are some real world use cases of the COVID-19 Interoperability Alliance value sets. And I provide these examples in case they stimulate ideas for how you might apply them within your organizations as well. Okay, so as promised, I'm going to spend most of our time talking about best practices for value set, authoring, and maintenance. And I've divided this part of the discussion into three sections. And by the way, let me pause here because I see that there are there's some activity in the chat, and I'll welcome you to ask questions along the way. And Connie has volunteered to relay to me. If I don't notice them occurring in the chat, feel free to just type your questions and Connie will relay them to me. So I don't see anything that I need to respond to right now. So like I said, I've broken this section into three: a request, author, and update phase of the value set lifecycle. So let's start by talking about some best practices during the request process. And so the first best practice I wanted to convey to this group is that it's really important to clarify inclusion and exclusion criteria. So when there's a request for a value set, it's really important to know what's in and what's out. Because a value set at the end of the day is a roll-up of terms. And if we take heart failure as an example, which was a value set that was requested for someone who was studying COVID-19, heart failure can mean a lot of different things. And when we get a request for something like heart failure, what we're thinking of are all of the possible variations of heart failure. That could mean acute and chronic heart failure, systolic and diastolic heart failure, which is the old classification. There's a newer classification where heart failure is classified as heart failure with preserved or reduced ejection fraction. And then you have a mixed bag of non-specific terms like heart failure not otherwise specified, lurking through different kinds of terminology. So that was kind of what we thought when we heard a request for heart failure. But then what we actually heard from someone who wanted a heart failure value set was that they were specifically looking for acute heart failure because they were doing research, and what they wanted to understand was whether a patient had new onset heart failure as a complication of COVID-19. And so they really were not interested in chronic heart failure. If someone had chronic heart failure and then also got COVID-19, they weren't interested in those patients. They were looking at patients with acute heart failure as a new onset episode, possibly within the context of a hospitalization. But anyway, you get the idea that you really have to think about how you groom the inclusion and exclusion criteria for value sets depending on your particular use case. So that was one example. Another example of a request that we received was for ageusia, which means a loss of sense of taste. And when we received that request, we interpreted that as both complete and partial loss of taste. And that, in fact, was kind of on track with what the requester was looking for. Because when you start looking at terminologies, and whether it's SNOMED or ICD-10, where we can have representations of ageusia, we found that there were things like ageusia, hemiageusia, loss of taste in the anterior 2/3 or the posterior 1/3 of the tongue. And so you could see that there's a lot of, variety of things that all would roll up to the concept of ageusia. And so that happened to be the right place to land, as opposed to having a specific value set for partial loss of taste. Really, this ageusia value set that had all these different varieties of loss of sense of taste was what they were looking for. Okay, so again, it's important to define exactly what's in scope for any individual value set. Another best practice that we often like to apply during the request phase is to figure out how to group or split the members of value sets. Generally, I tend to be a splitter, and I'll have a couple of examples here where we had to kind of make that grouping versus splitting decision. So, and for some of these, I'm kind of oversimplifying just for the sake of storytelling, but hopefully this will convey the idea. So there was a request for a value set for change in bowel habits. And the conundrum we faced was, do clinicians actually document literally change in bowel habits, or do they say that a patient might have constipation or diarrhea? And what we landed on for the value sets that we authored for this particular request was to create one value set for constipation and another value set for diarrhea. In SNOMED CT, it turns out that there is a parent concept called altered bowel function. But our thinking was that when clinicians are documenting, rather than having a coded term for altered bowel function, they might tend to be a little bit more specific and say whether the patient had constipation or diarrhea. If we wanted a higher level, was there any altered bowel function, you could take the union of the constipation and diarrhea value sets. And if the need ever arose where people were actually coding at the level of altered bowel function, we could create another value set for that, but we didn't do it at the time. And this is in consultation with the requester, kind of figuring out, okay, what is it that you requested versus what exactly are we going to author for you? And so we decided to split that into two. Early on, we also got a request for COVID-19 comorbidities. Now, this is actually a mixed bag because if we threw in all of the comorbidities of COVID-19 into a single value set, we were pretty sure that we were going to have disagreement around whether people felt like, Alzheimer's disease or obesity or other things were considered to be a comorbidity. So what we decided to do was to create individual value sets for COPD, diabetes, stroke, and all the other things that could potentially be considered a comorbidity. And we ended up adding metadata, for example, a comorbidity attribute that would allow people to kind of sort and filter through all the value sets that we offer, and then to decide for themselves whether they considered those to be comorbidities and whether to use them or not. And so it's a more granular way of providing the information and not constraining any particular user to our definition of what a comorbidity might be. Okay, so grouping and splitting can have important implications for usability, and so that's an important decision to make. Again, I tend to be a splitter because I feel like when you split, other people can look at the more granular building blocks and kind of mix and match. Whereas if you group, it makes it more difficult for people to split after the fact. So, but that's just a preference on my part. One more best practice in the request phase is that I like to provide a little bit of consultation and let people know when a value set might not do everything that needs to be done, and sometimes you need to use complementary technologies to achieve a goal. So as an example, when we had a request for a fever value set, we found a variety of terms across multiple code systems that all rolled up to the concept of fever. And so I've listed some of them here, fever due to infection, hyperpyrexia, acute rise of fever, intermittent fever, etc. So you can see there's a variety of different ways to say that someone is febrile. And while there are coded terms, we would often remind people that another way to see if someone had a fever is to look at their vital signs, because nowadays, pretty much everybody has vitals recorded. There's going to be a body temperature, and there's probably a short list of codes that roll up to body temperature. And then you would need to apply some expression logic against the body temperature, because you need to know the value and the unit of measure. And you could set your own cutoffs, whether it's 38.2 degrees Celsius, 101 degrees Fahrenheit, 101.3 Fahrenheit, or whatever your cutoff is. You can decide based on a patient's temperature whether they were febrile or not. You could decide whether you wanted multiple instances of a temperature that exceeded a certain threshold value. But then that way you have more flexibility in determining whether the patient was febrile, as opposed to using what someone codes as fever and kind of relying on their subjective interpretation of what fever is. So there's not always one way to do things. We could determine if someone is febrile through a couple of different methods that I just described there. But again, it's an example of how we might want to be consultative at certain points in the request process and say, hey, did you know there's another way that you can skin this cat? Another example is with cough. And while we could create a cough value set, and you can see some of the members that we listed here, I also caution people that when it comes to things like symptoms and signs, it might be less reliable to expect there to be coded data for these kinds of observations, symptoms and signs within electronic health records, just because from what I understand, these types of observations are more likely to be documented in a free text note as opposed to a coded list of observations. And so while we can author these kinds of value sets, you might have to do a natural language processing step to extract the corresponding coded data from free text before you can mash it up with a value set to see if some symptom or sign was present or absent. Okay, so applying complementary technologies when necessary may be an important part to rounding out your entire solution, where a value set by itself doesn't solve your problem alone. Okay, so let's move on to the authoring phase, and I'll pick up the pace a little bit because I know we have about 15 minutes left, and I'm standing between you and happy hour. So when we author value sets, we prefer to use intentional or rule-based definition. That is not a misspelling, it's intentional with an S, which means that we're using rules. We're using logic to define membership of a value set. So value sets typically have definitions, which are the rules, and then expansions, which are the resultant output when you apply those rules and explode that into kind of a final flattened list. So for example, I have a screenshot here where a rule-based definition would be to take ICD-10-CM and take type 2 diabetes mellitus, whose code is E11, and include all of its descendants. And through that one rule, if we were to execute that rule and run through the ICD-10 hierarchy, it would explode into 116 terms. And so you can see how it can improve your efficiency for value set authoring, as well as make it a much more scalable process when it comes time to recalculate the value set during a future update. And so taking this intentional rule-based definition it has several advantages over handpicking all 116 terms, as I think you can obviously see. And there are caveats around how does the source terminology handle inactivations of terms. Sometimes instead of inactivating a term and keeping it there, they'll simply just delete it. So you'll have no record unless you had a prior version available. You might never know that that term existed. So how are inactivations or deletions applied? And also with polyhierarchies, sometimes things get complex because if you take something like SNOMED CT, for example, which is a polyhierarchy, meaning any term could have more than one parent potentially, you get situations where you might grab hypertensive disorders and you're expecting to find things like primary or essential hypertension and secondary hypertension, but you also get things lurking like eclampsia and preeclampsia. And that may or may not be what you intended to capture. So you just need to be familiar with the terminologies and their hierarchies and their relationships, and always verify that your rules are actually yielding the expansion members that you're expecting. Another authoring best practice is to try to be as comprehensive as possible. And I use RxNorm as an example here, where we're actually looking at remdesivir terms within the RxNorm ontology, because when you ask, is a patient or did a patient receive remdesivir, there are many more terms than just remdesivir as the ingredient. So in this table, you see a variety of RxNorm terms, and I've thrown their term types into the far right column just to illustrate that there are many different levels at which you can represent drug information. So you've got not just the ingredients, but you can see there are some routed medications and dispensable products, and there's some brand names, and you can see how it can be very granular in terms of how the drug data are represented. And oftentimes from a value set authoring and maintenance perspective, it's not just as simple as saying, grab remdesivir and include its descendants. Because RxNorm is not just a flat hierarchy, it's actually an ontology with rich relationships where these terms are all related to one another with some very defined relationship types. And so it's not just as simple as saying, grab everything related to remdesivir, because that query can be very complex. We have some best practices at Clinical Architecture for how we can efficiently and comprehensively capture all these terms. And it's probably out of scope for this conversation, but there are ways, depending on the code system, that we have some best practices for how to efficiently and comprehensively capture all these terms. So just be aware that terminologies can be complex, and it can be your value set could potentially be improved in terms of its comprehensiveness depending on the approach that you take. Another authoring best practice, as I mentioned earlier, is to think about how inactive terms are handled. And the reason I bring this up is because as we saw things evolve related to COVID-19, there were often an initial stab at what terms we might want to use. And so we're looking at some LOINC terms, and this is a partial list of SARS-CoV-2 PCR terms within, I didn't have enough room to put all of them in there. And thanks, Connie, for the reminder. And basically, there were pre-release terms that were proposed that people might have started using within their EHRs. And some pre-release terms might ultimately make it into the final official versions of the terminologies, and some might not. This term that is in the second row, which is marked as retired, is something that we found as, I think this was a pre-release term, but it's no longer in the current active version of LOINC. But the reason why we support retired terms in the Alliance value sets is because people might have used them at one point. And from from the way that I understand, these codes are often used in EHRs, especially if they're natively used to code things in EHR workflows, is that nobody ever goes back and swaps out retired terms for active terms. Or if there's a mapping from a local terminology and a mapping to a standard code system, sometimes mappings are outdated and they haven't been remapped to the corresponding active terms. And so for that reason, we feel that it's important in support of people's research or decision support or whatever other use cases where they're consuming value sets to support retired terms as much as possible, to make it easier for people to match against the entirety of what might be floating out there in the healthcare ecosystem. So we try our best to support inactive terms. A couple more slides related to best practices around updates and maintenance. So aligning on a workflow and what the stewardship looks like for any given value set or collection of value sets is important. We have a pretty small ragtag team of people working on the COVID value sets at Clinical Architecture. We also have day jobs, but we do have enough hands involved where we do need to make sure that we're in alignment on what the processes are and the roles and responsibilities of the people who are working on the value set, so we're not stepping on each other's toes. So from an update perspective, we support both scheduled updates as well as ad hoc updates, because every now and then something important happens, or big changes or additions or removals. For example, when the vaccines first came out, we hadn't had a scheduled update planned, but we thought it was urgent enough that we add some CVX codes to the Alliance value set so that we could represent the vaccines, because that was kind of hot off the press. So what does that look like alongside the publication and distribution process? And roles and responsibilities, is there a process for someone who authors or reviews or approves value sets? And are we approving value sets for publication? And what do those processes look like? So these are things that need to be defined within any organization that's handling these value sets. And then the last best practice is kind of connected to one of the authoring best practices, to use intentional rules, but you want to be able to make incremental updates to your value sets, because terminologies evolve over time, some more than others. SNOMED tends to evolve very rapidly, sometimes RX norm, even LOINC, ICD-10 issues annual updates. And if you've used rule-based definitions of your value sets, you make it easier to be able to find the deltas between your value set numbers over time. So as things change within the underlying terminologies, simply re-executing those rules will yield a new value set membership, and we can compare the before and after and say, here's what's different, here's what's been added, here's what's been removed. And then it makes it easier for you to tell with pinpoint accuracy what those deltas are, and then to evaluate whether that is in line with the scope of your value set or not. And I can't underscore how important this is, because it's often not as exciting to think about updates and maintenance, but it is so critical if you want to have value sets that stand the test of time, to be able to update them incrementally. Because if you don't have a strategy for incrementally updating the value set, then your update process will basically consume the same amount of time as it took you to initially create the value set, because you basically have to recreate the value set in order to get an update, unless you have a process for calculating deltas. I'll just leave it at that. So in summary, we talked a lot about the semantics of value sets. The value sets, they convey semantic meaning, and a lot of the best practices that I mentioned are around, how do you clinically curate a value set? Because basically the result of your value set becomes the actual meaning of that value set, but you need to make sure that you're doing all the right things to scope it properly, to group and to split, and to figure out how you're going to manage this, because you want to convey the intended meaning, right? So there's a lot of thought that goes into that. And some of the best practices that I talked about are really related to helping to optimize the accuracy, the efficiency, as well as the comprehensiveness of the value set. So by applying a lot of these best practices, we can really make sure that we're hitting the target. And again, just a reminder, if you want to either anonymously consume, or if you want to actively participate in the COVID-19 Interoperability Alliance, check out covid19ia.org. And just a parting thought is first a reminder that there are many different reasons, a lot of different use cases for the consumption of value sets. And that includes COVID-19 and beyond, because while this effort has been focused on COVID-19, we could potentially see an expansion of our efforts to include other notifiable conditions and other public health issues. And so we welcome the community to join us, to collaborate, talk to us if you have ideas or suggestions. We'd be happy to hear from you. And that's all I had, so thank you very much. Connie, I'll turn it over to you.
Hi, Dr. Lee. Thank you for this great presentation. We do have just a couple of minutes, and there are 3 questions now in the question box. So the first one is, how often are the COVID-19 value sets updated with the different update cycles of the terminologies used?
Oh, that's a great question. We haven't stuck to a hard predefined schedule, but generally we're updating. First of all, the value sets are always being updated, and from the workshop you can see literally up to the second what the value sets look like. But from a kind of a publication en masse, we generally do that every couple of months.
Okay. Then the intentional value sets tend to contain many codes. Won't this cause a big maintenance burden for end users?
Yeah, great question. And yes, value sets often tend to have lots of codes, and sometimes they can be complicated. What we're trying to do as part of the Alliance is to do the heavy lifting so that we can take that burden of authoring and maintaining, and then hopefully giving a list that is in line with your expectations. That's not always the case. Sometimes people say, yeah, I see what you have here, and I was looking for something a little bit different. And we can certainly have conversations around that too. But our goal is to try to make it a little bit easier for the community, so not everyone has to reinvent the wheel.
Okay. And the last thing was just a comment. It says more processing power and knowledge will be needed, and many organizations just don't have that expertise.
Yeah, and I can see how that's kind of a follow-up. And we have, at Clinical Architecture, we have the software tooling to do some of the fancy calculations, working with hierarchies and ontologies, and we have fancy ways of using rules that are not just based on relationships, but also attributes and lexical definitions. And so we can get really fancy with that and hopefully yield a value set that conveys the intended meaning. So yeah, and I hope Soraya, that's something that we can do to benefit you in your efforts. So feel free to talk to me if you have more detailed questions. But great questions.
Thank you so much for that presentation. Very interesting. A lot of work went into that, clearly. I just want to remind the people in this room that there is an evaluation that we would like for you to take, and we are giving a $50 Amazon gift card, and the winner of that is Brittany Hicks. So congratulations, Brittany Hicks, and we will get that to you in the future here. So thank you all for participating, and please take the evaluation.
Thank you very much, everyone.
Looks like there's still some folks in the room.
And thank you very much, Connie. I hope